epistaxis or bleeding from within the nose. It is one of the most common and often most difficult to treat emergencies in ENT. So, I will be discussing epistaxis under the headings of vascular anatomy, classification of epistaxis, causes of epistaxis and also management. So, in vascular anatomy, the blood supply, that is the arterial and also venous supply of both septum as well as the lateral wall of nose was already discussed. There are some key clinical areas in the nose which are mainly Little's area, and you know the Little's area, which is situated on the antero-inferior part of nasal septum, and the arterial anastomosis there is called the Kisselbach's plexus, which is mainly by the anterior ethmoid artery, then the posterior septal branch of sphenopalatine artery, then from below it is the nasal branch of superior labial artery and also the nasal branch of gastro-palatine artery. And bleeding from this Little's area constitute around 90% of causes of epistaxis in young children, and in young adult. And this part of the nose is very much subjected to changes in temperature and also moisture. And this mucosa of this area is highly fragile, so that it will lead to bleeding. Okay, so that is a common site of arterial epistaxis, that is the Little's area. And this Woodruff's plexus is a submucosal venous plexus which is situated in the posterior part of the lateral wall of nose. Mainly this is otherwise called the nasopharyngeal plexus. Woodruff's plexus or the nasopharyngeal plexus is on the posterior part of nose or posterior part of the lateral wall of nose, or more precisely it is inferior to the posterior end of inferior turbinate. Okay. And that is a cause of epistaxis in adults and also in older persons. And it is mainly causes epistaxis in older people who are hypertensive or having on anticoagulants or having atherosclerotic disorders. And there is also another area called Brown's area, which is also on the posterior end of the septum. So this is on the anterior part of septum, and this Woodruff's plexus on the posterior lateral wall, and Brown's area on the posterior septum. Okay. And what is the artery of epistaxis? It is the sphenopalatine artery. Mainly the posterior septal branch of sphenopalatine artery. The sphenopalatine artery, after coming out of the sphenopalatine foramen, it divides into a posterior septal branch and also a posterior lateral branch. And this posterior septal branch is coming anteriorly, and that is called the artery of epistaxis. And the most common site of an venous bleeding is the retrocolumellar vein. And this causes bleeding more in children, and this retrocolumellar vein is around 2 millimeters behind and also parallel to the columella, and that is why it is called the retrocolumellar vein. Okay, so this is regarding the vascular anatomy. Coming to the classification, there are so many classification in different textbooks, but this is according to Scott Brown textbook of otorhinolaryngology, which is a standard textbook for postgraduate residents. Okay, so depending upon the cause, this can be primary or secondary. Primary epistaxis is without any known cause. This constitutes around 70 to 80% of bleeding. That is idiopathic, without any known cause. Secondary can be due to other causes like trauma, surgery, anticoagulant use, etc. And this is depending upon the age, can be divided into less than 16 years and more than 16 years. And depending upon the site, that is anterior to pyriform aperture. Okay, if it is anterior to the pyriform aperture, it is called anterior epistaxis. That mainly constitute the columnar part of septum, then the mucocutaneous junction and also the nares. And the posterior epistaxis is posterior to the pyriform aperture, which can be again divided into those on the lateral wall, those on the septum, and also on the nasal floor. Okay, so depending upon the cause, depending upon the age, depending upon the site of bleeding, can be classified like this. The next is causes of epistaxis. The causes can be local causes, that is related to the nose, or it can be systemic causes like conditions, systemic disorders which lead to epistaxis, or there are some contributing factors. So let us see one by one. The most common cause of an epistaxis include local causes like trauma, and this trauma can be a direct blunt trauma. It can be an nasal fractures or nasal lacerations, or this can be a digital trauma like frequent nose picking or insertion of foreign body, and then mucosal desiccation mainly due to extremes of temperature, climatic variations, and also overuse of chemicals like cocaine, then ammonia, acid fumes, and chromates. The next is due to inflammation. Inflammation comes allergic rhinitis, then infections, mainly the viral upper respiratory infection and also sinusitis. And vaginous granulomatosis is there, midline granulomas, and also nasal polyp. There are so many conditions which can be listed under inflammation, but these are the most common causes which can be listed as causing epistaxis due to inflammation. Next is neoplasms. Neoplasias can be both benign and malignant, mainly papilloma, esthesioneuroblastoma, carcinoma of nose, sinuses or nasopharynx, and also juvenile nasopharyngeal angiofibroma, which causes profuse, painless and recurrent bleeding in the adolescent age group. And under the systemic causes, mainly we can divide it into diseases like hypertension, or it can be hematological disorders or vascular abnormality. So under hematological disorders mainly comes the primary clotting abnormalities like what? Like hemophilia or von Willebrand's disease. Okay, then thrombocytopenia or platelet dysfunction like idiopathic thrombocytopenic purpura or leukemia. Okay, then these are primary, and secondary to clotting abnormalities or platelet dysfunction, that is clotting abnormalities or platelet dysfunction caused by some other disease like what? Like chronic renal failure or hepatic disorders or liver disease. Okay. Then there are also drug-induced, some drugs are causing epistaxis like what? Salicylates, some chemotherapeutic agent and also antiplatelets like warfarin can lead to clotting abnormalities or platelet dysfunction or thrombocytopenia, and that is also will lead to epistaxis. So this four main headings comes under hematological disorders. Then there is also another spectrum of vascular abnormalities, hereditary hemorrhagic telangiectasia, hemangiomas and also AV malformations. And there is another group of, another important cause of epistaxis which we call as an hypertensive epistaxis. But in that category, in most of the cases, the patient may not be known hypertensives under treatment, but because of epistaxis, because of the anxiety and stress, the blood pressure may be elevated in that case. So they cannot be categorized under the patients of hypertensive epistaxis. Okay, so these are the causes, which is local, systemic and also hypertensive epistaxis. Then next is management, and that is the most important thing. You all know that this epistaxis is an emergency. So an effective management of epistaxis, especially adult epistaxis, needs an incremental sequence of management strategy, and this is a flow diagram for management of primary adult epistaxis. So the first important thing here is resuscitation of the patient. That is the most important one, because there is a high prevalence of cardiopulmonary disorders associated with epistaxis. Resuscitation is the most important one. But in most cases, around 70 to 80% of epistaxis comes from the trauma and emergency department. The resuscitation must have done there. If not, you have to go with the resuscitation techniques like, so start with the primary survey. Along with that, address the airway also. Especially if the patient is coming after a road traffic accident, there may be a chance of clot in the oral cavity that has to be removed. So suction is also very important along with resuscitation, and always make the patient hemodynamically stable. For that, large bore IV access, and along that take blood for laboratory investigation. It is always better to have 2 large bore IV lines. Minimum 2 large bore IV lines are needed, and also monitor oxygen and keep under oxygen, and hemodynamic stability has to be monitored. So all these, and if there is bleeding, ask the patient to pinch the nose. That is otherwise called the Hippocratic technique. Okay, Hippocratic technique. The word seems to be something great, but it is Hippocratic technique is simply pinching the nose. And along with that, you also ask for the history. So we already discussed about the causes. So everything in that may cause an epistaxis, like history of any anticoagulant drug usage, history of any hypertension, history of trauma, history of liver diseases, history of alcoholism. All the causes that may lead to epistaxis should be very quickly asked also along with the resuscitation measures. After resuscitating the patient, go with the initial examination of the patient. Initial examination, and it is always better to do the initial examination in a semi-recumbent position, and always call for nursing assistance, because nursing assistance is mandatory. And don't forget to wear personal protective equipment, especially the visors, protective glasses, and also the protective wearing, because there is chance of an aerosol contamination. And the equipments needed are the minimum equipments: headlight, then the suction apparatus, it is mandatory, vasoconstrictor solution which include xylocaine and also adrenaline, then anterior and posterior nasal pads, and cautery machine, and it's better to have a bipolar cautery if available, and also endoscopy. In centers, higher centers always keep an endoscopy also along with the equipments. Okay, so by doing the initial examination, the thing is whether you have located the vessel or not. Can you locate the bleeding point or not? If you can locate the bleeding point, if the answer is yes, you can locate the bleeding point, then the therapy, it is called the direct therapy. Okay, direct therapy. And what is this direct therapy? I already told you. If it is a minor point in the littles area, it will be stopped by just pinching the nose for around 5 to 6 minutes. Or you can cauterize it with a silver nitrate cautery. Silver nitrate cautery, chemical cauterization. Okay, the anterior bleeding point, it is better to have a silver nitrate cautery than a bipolar cautery, because bipolar cautery is little more painful to the patient. So you can cauterize it with silver nitrate. And the posterior bleeding point, it is not easy, it will not be easy to cauterize with silver nitrate. So if the bleeding point is located posteriorly, the key clinical area we already discussed, and if the bleeding point is posteriorly located, it is always do a bipolar cautery of that area. And if you cannot locate the bleeding point, then it is better to go for an endoscopy. Do a diagnostic nasal endoscopy with a 0-degree endoscope and locate it. If you have located, then again go with a direct therapy with either pinching the nose or cauterization, either a silver-nitrate cautery or electric cautery. And even with the endoscopy, you cannot locate it. Then what will you do? You have to go with the indirect therapy. What is indirect therapy? And anterior nasal packing is a mainstay of an indirect therapy. Anterior nasal packing, conventionally you can use a ribbon gauze impregnated with a petroleum jelly or antibiotic ointments. And now the more easy and patient friendly things like Merosil or Caltostat is there. It's very easy to pack the nose. And also there are balloon catheters, especially in case of a posterior epistaxis. Okay. And once you have put it antinasal packing or antinasal pack, it is better to keep it for minimum of 24 hours to 48 hours. Okay. And with indirect therapy, and if you have located the bleeding point and it is cauterized, and you can discharge the patient on the same day after a period of around 2 to 3 hours of observation. So after doing an antinasal packing, the bleeding controlled. Then if you have put the antinasal pack, keep it for 24 to 48 hours, or if the bleeding already controlled with the cauterization, you can send the patient on the same, discharge the patient on the same day. And even after you putting the indirect therapy like antinasal packing, still the patient is continuing to have continued bleeding. Then there is need of a posterior nasal packing also. And along with that, start with the systemic medications. One systemic medication given is tranexamic acid. So it can be given 1.5 gram 3 times per day. And if the bleeding is not controlling with an anterior nasal pack, go for a posterior nasal packing. And again, this Merosil posterior nasal packs are available, and there is conventional formed gauze made posterior nasal packs are there, or for easy to use is a Foley's urethral catheter. This Foley's catheter can be inserted through the nose, and when you see the tip in the oropharynx or below the or posterior to the soft palate, inflate it at least with a 15 ml saline, and then withdraw it or pull it forwards so that the inflated end will press on the nasopharynx, will be in the nasopharynx, and this Foley's catheter along with that give an antinasal packing and secure it in the over the columella. But care should be taken to protect the columella. Put some gauze or something over the columella, then only fix the Foley's catheter, because once you have injured the columella, the scar will be permanent, and that is very unethical, and you are doing a crime to the patient. So always protect the columella before fixing any pack, especially the catheter, Foley's catheter, and keep it for minimum of 48 hours. So this antinasal packing you can keep for a period of 24 hours, but posterior nasal packing always better to keep it for 48 hours. Okay. And again, it is bleeding is not stopping with your posterior packing. The next is ligation, and for the ligation, the commonest vessel which is ligated is the sphenopalatine artery. So endoscopic sphenopalatine artery ligation, S5. Okay, so the hierarchy of ligation is, first is sphenopalatine artery, it's a surgical technique, endoscopic sphenopalatine artery ligation, and second is internal maxillary artery. Then the third is external carotid artery, and fourth is anterior or posterior ethmoidal artery. Okay, this is the hierarchy of ligation of arterial ligation in case of epistaxis. So the commonest is endoscopic sphenoparietal artery ligation, which is comparatively easiest. Okay, and that is indirect therapy. So under indirect therapy comes a packing, either anterior nasal or posterior nasal packing depending upon the site of bleeding, and also ligation of the arterial ligation, and still it is. So after indirect therapy, either bleeding can be controlled or continued bleeding. If it is again continued bleeding, you have to go with an embolization under digital subtraction angiography. Okay, so digital subtraction angiography plus embolization. It's the ultimate. So this is the flow chart of management of epistaxis. Now we will discuss on the different types of nasal packing, then also the surgical approach or surgical technique of ligation of arterial ligation, especially the HESPAL.